Good morning, ladies and gentlemen. Please, if you decide on staying here with us in the morning, then please have a seat. My name is Ágoston. I am director of the Semmelweis University, and it is my utmost pleasure to greet you here. We are all very happy who are taking part in the organization of this conference, that we can be pioneers in Eastern and Central Europe to start joining to this association, the Association of Academic Health Centers. I think it is extremely important to be a member of such an association, because it's obvious that we have to face new problems, new questions, and new solutions are needed. And to get together and to share our problems and our experiences might be very helpful in finding out those ways which can lead us to a better future. I would like to greet the president of the association, Professor Wartman, who will take over after I have greeted you. It was a pleasure to meet him yesterday. We have got a wonderful short introductory program in the old building of the Semmelweis University, where we have got acquainted, and I have learned already yesterday a couple of very important things from him about smiling and other things. It is very important. The most recent information, which I have just received 5 minutes ago, so it is brand new as a piece of information, is that he's also a fan of Mahler, the composer. You were talking about the yesterday music, Dvorak. He confessed, he admitted that he was very positive that the music must have been by Dvorak, but he didn't dare to say. But he did dare to say that Mahler is also among his favorites, which is the same as me. I think that a university has two extremely important needs. The one is tradition, and the other thing is the innovation. The two things seem to be contradictory, but I think in my mind the two are extremely close to one another. There is a very famous quotation from Goethe, the German poet, and that is something like this. I don't quote it precisely, but the message is the following. What is it that parents can give their children? Roots and wings. And I think that the tradition and the innovation, so the roots and the wings, are those two qualities which an academic health system or a university, whatever we call it, must have. Without tradition, it is very difficult to look in the future. Without having a vision to the future, it is very difficult to enjoy the tradition. So I think that my most important feeling or vision about a university is these two things. And it is probably not a surprise for you that I start my thoughts with this, because Semmelweis University is 244 years old. And let me tell you that it was exactly on this day in 1769 that Maria Theresia has founded the famous Nagyszombat University, which is actually the starting point of the Semmelweis University. So this day today, 7th of November, is a celebration day in this respect. The other thing which is very important also, and that will be probably the main topic for us in the next 2 days, is that the triple function of a university as well as an academic health center is in this order, as I say: education, research, and patient care, clinical care. And these three things are extremely strictly interwoven and intermingled, and the basic question is how much this synergism can be used for making all the three, one by one, more and more successful. That is the basic question of this conference today, which actually has the name Collaborative Healthcare, Changing Paradigms in Education, Clinical Care and Research. And in the morning when I woke up, I was thinking a little bit probably too freely, not necessarily correctly. But what came into my mind is that we can imagine the following situation. There is a block of building where education is going on. There are teachers there who teach. It's good. There is another building next to it or a little bit farther away from it, where there are people who run research work. It's a research institute. They are doing their work also extremely diligently and probably successfully, but independently from the other. And there is yet another building where clinical practical work is going on. And these three could survive probably alone, but how much better it is if we put together these three. And that is what is the topic today and tomorrow, that how can we take advantage of having all the three on a level, master level, not just living next to each other, but put together the experiences and the common questions which are to be solved in a similar way. I think that if we break down this message to each of these three points, and we put together these, and we start this thinking that it is not enough to put together these three things in one building, and yet the individuals will only run research, some others will only educate students, some others will only do the healthcare. The main thing and the real thing is that in one person, at least two of these three, if not all the three, are merged and done together. And in this case, in the mind of the researcher, teacher, and practitioner can be put together in a very effective way. And to go along with this line of thought, I think that it's also very important that when we talk about new strategies which are needed, then, for example, if we think about the education, it is logical that education cannot survive without research, at least not in a university level. Primary school or a grammar school is very important. Teachers who are teaching there are normally transmitting the knowledge which they have obtained from books and from other teachers. What we do in a university is we ourselves take part in the production of new pieces of information, new knowledge, and this new knowledge is digested and given back to the students, and I think it is much more, and that is why we call ourselves universities, because we have to do it, the teaching in a much higher level. But if we think about the research as such, we also can see that these are very important and precious, valuable pieces. Small little teams, 2 to 3 people with an assistant who do their research isolated in a lab. They probably produce good papers which will be accepted. But how much better it is if in a university there are main streamlines of research work, and the little teams are somehow members of this big team, and their research work is added to a big streamline. And I think it is a very important thing to think about, because a small team is less and less capable of producing a grant application which will be accepted finally. 20, 30 years ago, it was relatively easy to get the money for a research like this, but by now it is impossible anymore. And if we go on and we ask how about the clinical work, it is also very important that the individual disciplines, clinical disciplines, are not lonely, not separated, they are put together, and if they are put together, then their work, their collaboration can be taken advantage of much, much better. And if all the three are put together, that is the best. And I think if we can move on with this line, we can say that it is not enough if in a university all these things are put together. It is very important, but it is not enough. And our conference today is a proof that universities have to merge, of course not in a real way, but in the way of thinking. So a single university, however deep the traditions are and how good the future visions are, cannot stand alone. We have to share our experiences with one another, and just to talk about things can help a lot. And if we do even more, and if we go farther, and we do not only talk about these things, but we do things together, then it will be even better. Just a few examples to that way of thinking. Dr. Jörg Weidenhammer is sitting here in the first row, my old friend, who is the creator of an extremely productive collaboration between a non-teaching clinical unit hospital in Germany and the Semmelweis University. Our German students, after a couple of years, after they have taken their examinations in the elementary subjects, they can move on to Hamburg and they continue their clinical work there. And this collaboration is collaboration between health centers in the best way of the best sense of the word. And Professor Judith Mészáros is sitting a little bit farther behind, who is the creator of an extremely productive Swiss connection between Semmelweis University and a university there, the Lugano University, which also results in a number of students, a great number and even increasing number of students who are receiving their knowledge from ourselves, and they get a Semmelweis diploma, but they are living in Switzerland. And I could go on with these examples, but I think that we shall anyhow come to these questions today and tomorrow later. So the integration is very important in this sense, the collaboration is very important in this sense, and there is one more step, and that is that academic health center cannot be concentrating only on the basic clinical subjects. It is extremely important that the humanities are also somehow on the board, and in this respect Semmelweis University can also be very proud, because we have in addition to the traditional faculty of health sciences, faculty of public health services, which is very deeply infiltrated with not just clinical natural sciences way of thinking, but also sociology and such related things come up also. I think that before giving the floor to Professor Wartmann, let me quote it in this moment precisely three important sentences from three important persons, not necessarily medical doctors, but very important persons. The first one is Pasteur, who is, I think, a key personality in this respect. His words are as follows: "Science knows no country, because knowledge belongs to humanity and is the torch which illuminates the world. Science is the highest personification of the nation, because that nation will remain the first, which carries the furthest the works of thought and intelligence." And two very short sentences after that. Sir Francis Bacon in the 16th century wrote the following. It's a very famous three words quotation from him. In Latin, as it was put originally, was as follows: "Scientia potestas est." Translated to English, knowledge is power. And then I close the way of thinking with Anton Chekhov, the Russian, very famous Russian writer, another favorite of mine, who was actually a physician as well. Probably that's why his novels are so very perfect. A couple of hundreds of years ago, years later than Bacon, he said the following: "Knowledge is of no value unless you put it into practice." So what Bacon said is that knowledge is power, but this power is powerless if we cannot put it into practice. So let's put it into practice today and tomorrow, and I wish you a very, very successful conference, and welcome in Budapest in Hungary. Thank you.
Thank you so much, Rector Sell. I appreciate that very much. I want to say a few kind words about you. I had the absolute pleasure of meeting with you yesterday afternoon, and I got such a wonderful impression, because I meet a lot of leaders these days from around the world, and to meet one who is not only brilliant but humble at the same time, I think is a wonderful attribute, and I was very pleased to have the honor to meet you. I'd like to thank you. I'd like to thank your Vice Rector, Dr. Molnar, if you would please stand up, who also is very, very helpful. And our Director of International Relations at Semmelweis, Dr. Pop, if you could stand up, please, as well. They have all been working very, very hard with the staff, our staff from Washington, as well as the staff here in Budapest, and I think have done a terrific job in putting together what I think will be an absolutely wonderful and wonderful meeting. I do have just a few comments to make. I hope they're not too lengthy. I doubt that they will be. But You know, this is our first meeting in the Central and Eastern European area. And I think the agenda, as you could see, is very, very comprehensive and has a very, very broad range of institutions that are participating. And I want to apologize if the slide's a little out of whack or your country happens not to be on this slide, because I made the slide a few days ago, and I understand we have a few more countries that have come already on board. It's an astonishingly interesting list, isn't it? If you just take a moment and study that, I won't read each and every name, but what an interesting collection of individuals that we have here today. These are individuals who lead institutions from countries and regions that speak different languages, that have different cultures, profoundly different histories, different economies, and very different health systems. Yet I would tell you, ladies and gentlemen, that we all have something very much in common. And it is this commonality that brings us here today to Budapest. Is that regardless of all the factors that I mentioned, culture, language, economy, health system, history, we all want to do the same thing. We all want to improve health and well-being. And we want to do that. We want to do that by taking what we do academically, which is the teaching of medical students and nurses and all the other health professionals, the research that we do in basic research and applied research and clinical research, and make it work for patient care. We want to bring that all together. And that, in fact, is a unifying thing that we all have here in this room today, despite the enormous differences in history and culture and language and all that other stuff. We all want to improve health and well-being by bringing academics and patient care closer together. Let me just tell you a little bit about our association. It's part of an evolution. You know, the Academic Health Center, you can call it an academic health system, you can call it an academic health network, doesn't matter what the term is, but we are evolving with the times to bring academics and patient care integrated into alignment and closer together. It's a movement. It's like the center of gravity is moving toward this concept. And I would propose to you that our value proposition is what I would like to call the virtuous cycle. That is, the clinical and academic missions that we have, the teaching of students, the research that we do, and the patient care that we deliver, support each other. And by supporting each other, make the other better. You know, some people think about, well, we've got education over here, we've got research over here, we've got a hospital, we've got a clinic. They all do their thing and they're doing a wonderful job. But I propose to you that they would do an even better job if, instead of being separate in different parts and different components and different buildings and different whatever, that they work together. And that they work together by believing in their hearts that the other component, those who educate, are making patient care better. Those who do patient care are making research better. And research is making everything better as well. We need to aspire to work toward this virtuous cycle. And that's really the reason we're in this room today, and it's really the reason behind the Association of Academic Health Centers International. We started it in 2008 for the reasons that I think are clear to everybody in this room. We're all becoming more and more interconnected with each other, aren't we? And so we have so much to learn and so much to offer. And we should do that and to integrate our activities. We are the only international association of its kind, the only one that does this, that helps you become agents of change to enhance health and well-being worldwide and to strengthen your missions in an integrated and aligned sort of way. We're affiliated with the US-based Association of Academic Health Centers, which was founded more than 40 years ago, representing most of the US academic health centers. And please note that everybody can talk to each other and work with each other and come to each other's meetings. It's a very integrated group. Our guiding principles are very clear. Our goal is to help academic health centers apply knowledge to improve health and well-being while building the knowledge economy of their region. I want to make that very important point. We are more than just a scientific, educational, and patient care force. We are vital infrastructure for a community and for a region. We build buildings, we hire people. Companies grow around what we offer and what we build. And we create a structure that attracts people to come to work for us rather than leave and go work somewhere else. Very, very important, building the knowledge economy. A list of our members would take too long to go through, but we do have members in all the world's regions. It's just too many to cover. But I would just like to conclude by again thanking all of you for coming, having an open mind today and tomorrow. I hope to meet each and every one of you and have a conversation and talk about things. And good luck to everybody today. So thank you very much. It is now my real pleasure to introduce the chairman of our board of directors, an individual who I've gotten to know personally and professionally over many, many years, an outstanding leader, someone who holds so many titles at Penn State that I'm not sure I'll get them all, Hal, but I'm going to give them a try. He's CEO of the Penn State Health System. That's not enough. He's Senior Vice President for Health Affairs for Pennsylvania State University. He also holds the title of Dean of the College of Medicine. Did I leave anything out? He's our leader at present time. Please join me in welcoming Dr. Harold Paz.
Well, good morning. It's truly an honor to be in Budapest, to meet with all of you and to provide this overview of the academic health center concept. As Steve mentioned, I suspect I was invited to give the opening remarks in my role as chair of the board of the Association of Academic Health Centers back in the U.S. It's also a real honor for me to be here as the son of a Hungarian family and an opportunity to visit this country for the first time. This is truly remarkable and delightful for me and my family personally, so thank you very much for the invitation. What I want to do is spend about 20 minutes or so talking about the academic health center concept in the U.S. and to put it in the framework of one institution. And rather than spend a lot of time on the theoretical, I thought I would be more practical in talking about examples and show how an academic health center not only operates, but the impact, as Steve was alluding to a few minutes ago, the impact that it has on the community in the region to serve its ultimate mission. It's really one single vision and mission, which is to improve the health of the region, the state, and the nation. And that's our focus at our institution. But how we get there is sometimes complex, despite the fact that the concept itself is remarkably simple. We are part of a large, in the U.S. we call it a Big Ten university. The Big Ten is the league that is for athletics, and football is something that is a very popular sport, as you all know, in the U.S. So we're part of the Big Ten with some institutions you've probably heard of, the University of Michigan, Ohio State, and others. We're also part of an academic organization called the CIC, that not only includes those universities, but places like the University of Chicago, which is obviously known to many. But within Penn State, a university that has been in existence since 1855, there are 21 campuses. The main campus is in University Park, which is in the center part of the state. And the medical center sits 100 miles away. Let's see if I can, there we go. The medical center sits 100 miles away from the main campus in Hershey, Pennsylvania. Penn State has over 40,000 students. It's ranked among the top 10 most years, among the top 10 in the nation in overall research funding, and is known for not only healthcare, but many, many other programs in the sciences and the liberal arts. And for us, as part of this great university with a very rich history, our emphasis and our focus on this campus in Hershey is around the health sciences. And what I want to do is spend some time now talking about the model, talking about the concept of how we not only serve the health of our region in central Pennsylvania, but actually around the nation and through our collaborations, including our collaborations here, even around the world. So here's a snapshot of Penn State Hershey. We have on our campus over 1,600 students and trainees. Our focus, an important focus, is on research. And one of the things in the US that is highly coveted is a Clinical Science Translational Award. There are 60 in the United States awarded by the National Institutes of Health. These are awards that create centers that focus on taking research from the basic science laboratory, fundamental research, and moving it to clinical research at the patient bedside, with the ultimate hope that it's then transferred as intellectual property into the production of new types of drugs, biologicals, and devices, which ultimately improve the health of the nation and will be translated around the world. 24 departments, 5 major institutes like a cancer institute, a neuroscience institute, a heart and vascular institute, that bring faculty across various departments around a core mission around a disease state. Several hospitals within our system, about a 500-bed university hospital or adult hospital, a 72-bed children's hospital, a psychiatric institute, and a rehabilitation hospital. You can see the numbers up in front of you. A large number of admissions, almost 1 million outpatient visits at 63 clinics that are spread out around Pennsylvania, central Pennsylvania, where we provide more and more of the care. As a matter of fact, while only around 10, 15 years ago, most of the care we provided was inside the hospital, now at least half, if not more, of the care that our faculty provide is in the outpatient setting. We have outpatient surgery centers. We have literally taken over supermarkets and turned them into clinics where we have a primary care core. We call that a patient-centered medical core, which is family medicine, internal medicine, general pediatrics, with specialists from cardiology, surgery, a long list of specialists, and then in there, things like imaging centers, rehab centers, all on the outpatient basis, because there's more and more evidence that the better we get at providing care in the outpatient setting, the more cost-effective it is as opposed to hospitalizing patients. We built a brand new Cancer Institute building just a few years ago. There are no hospital beds in the Cancer Institute. We have same-day hospital beds so that in as much as possible, every single cancer patient will have their care as an outpatient. They come in first thing in the morning, they leave at 5 o'clock, they either go home if they're from the immediate region, or they stay at a hotel which is built across the street from the medical center. We think that's incredibly important. Patients who have significant, severe cancer really don't want to be in a hospital setting. Many of them are immunocompromised. The last thing we want to do is expose them to pathogens. And quite frankly, for the sake of their own quality of life, they're much happier going home or even being in a hospital than sitting in a hospital bed. But of course, we still have a very traditional cancer ward in the hospital, which has laminar flow rooms where there's negative pressure in the rooms to keep out pathogens. That is there, should it be needed, but all attempts to keep patients out of that setting, if at all possible. We have now almost 10,000 employees, faculty and staff on the campus, and we have a physician group, this is faculty, about 900 now, that work not only on the medical center campus, but at these 63 various sites across the central Pennsylvania region. And this is just a map of Pennsylvania. I think it's maybe a little difficult to see here on the slide, but this is the state of Pennsylvania. And these are where all these clinics and the 17 affiliated hospitals are located. We don't own all those hospitals. They affiliate with us. And some of those hospitals have our students that go there, our residents, our fellows, or we have our faculty, our clinical faculty, providing direct patient care. So for example, we may have neurosurgeons working 2 hours away at Moses Taylor Hospital. We have pediatric hospitalists working down here at Lancaster General Hospital. So we spread across the region. And in our value proposition, what we try to do is send our specialists out across the region to provide direct patient care to hospitals, because many of those hospitals have difficulty recruiting those highly specialized physicians. This is valuable for them, and for the physicians we recruit, they enjoy being part of these large academic departments where they can participate in education and research, but also have the support of other faculty back at the main campus of the medical center to provide support, backup, consultation for them. They're all interconnected by an electronic health record. We say we want to have one record for every patient, and unfortunately before electronic health records got very sophisticated, a patient could have multiple records, tests being repeated in different clinics without the other one knowing it. We have a single x-ray file, a digital x-ray file that is available and follows the patient. I'm a pulmonologist. I still practice, and I remember the days when patients would be carrying these stacks of film around with them. They don't do that anymore. Now we just go into an electronic database and pull up their films and look at them wherever the patient arrives, and that certainly is very important. And the most recent advent is through telemedicine, where we now have 6, and I think soon to have 7 hospitals connected by our telemedicine system. So even though they don't have neurologists who specialize in stroke, if a stroke patient arrives in their emergency department, literally within matters of minutes, one of our stroke subspecialists in neurology in Hershey will get on the computer, open it up, and through our telemedicine system be able to direct care for a patient with an acute stroke to open up the clot and reperfuse the brain and avoid the sequelae of a brain attack. And these are the types of things we want to offer more and more across the region because, as you heard, we believe this adds tremendous value. Well, there are in the United States 141 accredited medical schools. Of those, over 100 now are part of academic health centers, as Steve Wortman was alluding to a few minutes ago. Institutions that not only have a school of medicine, but other health profession schools, as well as hospitals and physician group practices. And if you go across the U.S., you will find many different variations on that theme. Penn State Hershey was one of the first that was fully integrated in the United States, and this is a model that we're seeing more and more of over the past decade or so, where there's an attempt to integrate the clinical side with the academic side so that all the benefits of having integration of the academic mission with the clinical mission can be realized. We've had institutions from around the world take a look at our structure, and others are now emulating that in the United States and also abroad. And we've talked to colleagues in Pennsylvania that have literally, in places most recently like Temple University, that have adopted this model, to Singapore, where they've looked at this model, and there are papers on this model in the literature that have been published going back 10 years if you're interested. But this is basically how it operates. So as I said earlier, we're part of Penn State University. We have a College of Medicine. We also have a College of Nursing, a graduate school that has various graduate programs, doctoral programs in the biomedical sciences, a Master's of Public Health degree in our Public Health graduate program, various professional master's programs. Most recently, in addition to our MD degree, our newest program is our Physician's Assistant Master's Program. There's a huge need for physician assistants and advanced practice nurses in the U.S. because the way we're delivering care is shifting so that family medicine physicians, primary care physicians are no longer doing the front line disease prevention and management, but are moving much more into chronic care management, where physician assistants and nurse practitioners are doing a lot of the early care, preventive care, and well visits. And this is a shift that's going on in the U.S., and it's going on rather dramatically. So we've seen the need to start this physician's assistant program as well as additional programs in our College of Nursing. And then, as I mentioned, within our Penn State Hershey Medical Center, we have a large medical group, our various hospitals, We have our health system that includes our 17 hospital affiliates, a number of different outpatient programs, as well as some tremendous growth in what we call post-acute care. And the most recent is being part of a home infusion company focusing more and more on home health care and more of our faculty working in nursing homes. And why are we doing this? Because we look conceptually at a continuum of care, beginning with the outpatient setting, beginning with primary prevention, all the way through to post-acute hospital care, where the care is being provided outside the hospital setting, in nursing homes, rehab centers, and at home. And we see more with the advent of what we call smart spaces, where we're going to be able to provide that care literally in the home through digital technology. A patient, hopefully in the not too distant future, will come into the emergency room. We can get them back into their home, install temporarily telemetry equipment to monitor them at home to decrease the need for inpatient acute care, which we think again will address opportunities for quality and will look at opportunities to reduce the cost of healthcare delivery while maintaining a high level of patient satisfaction. That's in the future, but there's no question in my mind that it is coming. So we're organized through this structure, and as Steve mentioned a few minutes ago, the structure that Penn State used was to have an office, and it has one person here, but trust me, there are 10 people in this box, the leadership team, that are responsible for all missions of our academic health center. We have a vice dean for education that on a day-to-day basis runs the educational mission, a vice dean for research. We have a chief operating officer of our health system, one for our medical center, the important chief financial officer, and then a few other individuals who deal with running of the institution on a day-to-day basis. This group and myself work together on a daily basis to bring together all these mission areas. And then I have a dual reporting relationship to the president of the Pennsylvania State University, which is the parent of our structure, as well as to the chair of the board of our medical center board of directors. We're organized as what we call in the U.S. a 501c3 corporation. It's a private, not-for-profit healthcare institution. Therefore, we have to have a board, but we also are part of Penn State, and ultimately we're owned by the Pennsylvania State University. So over the past several years, we've seen a tremendous growth in our academic programs, and it speaks to the way that healthcare is evolving in our country, and we expect more and more around the world. And this just gives you a snapshot of the programs that we've seen evolve just over the past several years. As I said, we started as a college of medicine. We were formed in 1963. We graduated our first class in 1971. But with that, we've seen a tremendous growth in academic programs that gets us up to our students and trainees of over 1,600. And just over the past several years, we've added a master's degree of Homeland Security that trains in public health prevention related to Homeland Security. This is offered online. Penn State has something called World Campus. It's one of the first adopters of technology where literally students from around the world can register for this course and take it and either get a certificate or a master's degree online. And now with the past several years of the advent of MOOCs, this is becoming more and more prevalent, and we're going to see more of this as a vehicle for how we conduct our educational programs for non-traditional programs. And who knows, maybe in the not too distant future, it may be part of how we conduct our training for some of our traditional programs as well. A number of nursing programs that were added, many of these are focused on advanced practice nurses, masters of public health, PhDs, and integrated biomedical sciences. We've had traditional PhDs in biochemistry, physiology, and so forth going back to the 1960s, but more and more the focus is on integrating the sciences around translation. Again, the acute care nurse practitioner program to take nurses with RNs and give them certifications to actually practice under the supervision of a physician, as well as the most recent program, our physician assistant program. And we also built a regional campus at University Park, the main campus of the university 100 miles away. focusing on rural medicine and primary care, because in the U.S. right now, the most pressing need is to train more physicians in primary care medicine. We need more specialists too, but from a workforce standpoint, we have some very acute shortages in primary care. And in Pennsylvania, in that central region, north central Pennsylvania has some very pressing needs. So we decided if we could build a regional campus there, it would help address those opportunities. In research funding, we've seen continued steady growth. A majority of our funding comes from the National Institutes of Health, which is the most coveted form of funding because it goes through a very extensive peer review process. We had year after year after year of increase until this year, when as a result of some very challenging situations with the national budget, and you've all heard, I'm sure, about sequestration, just to mention a few of the challenges, we saw a 20% decrease in our funding overall in 1 year. And in my 7.5 years at Hershey, this is the first time we saw a decline. Fortunately, in the past few months, since funds started to become re-released by the NIH, we've seen a significant increase, and we're going to work hard to get over that 100 million mark again, but it's been very challenging this year, and we're hopeful that we'll see an opportunity to get back on track in the next year or so, because research, as Steve said a minute ago, it is fundamental to everything that we do. It has a huge impact not only in our academic programs, but our clinical programs as well, and economically for our region is vitally important. For every dollar we get from the NIH, that translates to $5 to $7 in the local community in jobs and productivity that we see around the region. And if you consider how important that is, it's a strong argument for why we hope that funding will continue to get back on the same trajectory it had been on. One of the areas of huge focus, though, is in the area of translation, as I mentioned a few minutes ago. Moving discoveries from the laboratory bench to the patient bedside. A number of research programs at our institution have been very successful. Many of you have heard of a vaccine for herpes to prevent cervical cancer in the U.S., developed by Merck. That work actually started in a basic science laboratory in microbiology and immunology. Looking at the virus and then coming up with a way to develop a culture to study it. And then that translated ultimately into a vaccine, which is now literally saving lives. One of the first artificial hearts in the US and in the world was developed between engineers in the College of Engineering and in the Department of Surgery. So we think that this fundamental research translating into discovery, it becomes extraordinarily important, and we want to continue to move that forward. But the area of most significant growth has been our clinical growth, and this really reflects the role of academic health centers in the United States. As I said before, roughly about 100 institutions in America providing about 20% of the care. And that's remarkable, particularly if you think about the fact there are about 5,000 hospitals in America. So you can see the impact of these academic health centers, 100 institutions like this, that are providing a disproportionate amount of the care in two particular areas. One, what we call high-end tertiary and quaternary care, which is the most sophisticated kind of care. Transplantation, for example, running many of the children's hospitals in the nation, having many and most of the cancer institutes of the nation, but also providing primary care in their communities, particularly for the indigent and underserved patients in the inner city areas that have limited access to care. These are important missions of these institutions. We've seen tremendous growth in these programs over the past 7 years, and you can see here the growth in our outpatient visit, in our emergency department visits, our outpatient visits, as well as our inpatient visits. The inpatient numbers could grow even faster if we build more inpatient hospital beds, but we've made a decision not to do that. We think that since more of the care will be shifting to the outpatient setting, it's much smarter for us to build more outpatient clinics and figure out ways to move the patients to the outpatient setting rather than building more inpatient beds, which we hope in the not too distant future will become obsolete, which will obviously be much better for patients. So what's the focus? We talked before about two missions, academic and clinical, but really we look at the world as 4 mission areas. Education, which is what makes us distinct from other types of institutions around the country, research, patient care, and community service and outreach. All 4 of these overlap at an academic health center, brought together in the middle by innovation. And in our minds, innovation is the discovery that leads to breakthroughs not only in patient care, but also in education. What distinguishes us from a trade school is that our faculty aren't teaching out of textbooks. Our faculty are the discoverers of the breakthroughs and teaching it directly to the students. And that's what makes an academic health center, like all of yours, so unique. And if we stop innovating, we stop being in business. There are many, many, many examples of this day in and day out. And our focus has to be on continuing to do this research that creates this innovation that then translates into our other mission areas. So what are some examples of innovation in these different mission areas? Over the past several years, we've seen a shift to interprofessional education, where all these students in the past had been educated in silos. Now, more and more, we're educating them together as undergraduates and graduate students in teams, where we have nursing students, medical students, physician assistant students, pharmacists, all being educated at the same time. We think that's incredibly important. In the past, they were all educated separately in silos. And then we expected them to work effectively together in the hospital or the clinical setting in a team, using such things as a simulation center. We just spent $8 million a few years ago to build a large simulation center where students could learn together using mannequins and computers. We start the programs there, and now we're incorporating more of that into the classroom setting and the clinical setting as well. More of the educational program is on health systems, helping students understand that they're not working individually in one part of the process, but across a continuum. And that's going to be another area of emphasis. Educational pipelines. We have huge workforce shortages in the health profession, so we start in high school, which I know is different than in some of your countries, finding students who have an interest in biomedical research and healthcare, identifying them early on and continuing the training all the way through medical school, nursing school, and then on to residency, and then trying to find ways to get them to practice in our communities, because we are hiring more and more of these graduates working for our own systems. And then a large emphasis on community health and on global health. And about 25% of our students spend some part, it's more than 25% now, of their education somewhere around the world. We have affiliations with institutions in Europe, Asia, South America, and we have students, residents, and faculty that spend time in those countries delivering care or getting a direct education. We believe strongly that global health and global education are going to be very important aspects of what we do, and we want to make sure that every student before they leave has some opportunity to take advantage of that. In research, again, we're seeing this evolution from a much more siloed approach where departments work separately in the basic sciences and the clinical sciences to one that is much more integrated around translation, around institutional partnerships, as well as in technology transfer. And in particular, over the past several years, we focused on a new institute, the Institute of Personalized Medicine, which is an institute focusing on genomics and then identifying how individual genes determine phenotypic responses to treatments and drugs, and then using clinical research to identify patients that go into the large data banks using big data to then do new clinical studies, and we hope in the future ways to actually tailor individual care for each patient. At our institution, one of our chairs of the Department of Pharmacology was the first to identify that as determined by one's genotype, they are going to have different responses to warfarin, which would mean that the way they're treated is different. When I see patients in pulmonary clinic, I know that if I have a patient with asthma, 20% of my patients will not respond to an inhaled bronchodilator or an inhaled steroid based on their genotype. And in the past, we would have thought that, they just need more drug. because we didn't give them enough. Now we know we can give them as much drug as we want. They'll never respond because they don't have the receptors to respond to the drug. We see huge opportunities in personalized medicine. It's a cornerstone of a lot of the work we're doing. We think that is not only important scientifically, but clinically will be hugely important in the future, particularly in the development of new types of treatments and the approach to treatment care. And we're incorporating that in the education of our health science students as well. We think it's very, very important to do that. And then finally, our Center for Integrated Healthcare Delivery Systems. This is a joint center between the College of Medicine and the College of Engineering. Industrial engineers and physicians work side by side to develop new systems of care. In our emergency department, we had a huge problem a few years ago. It was built for 35,000 patient visits a year. We knew that we were rapidly going to approach 70,000 patient visits because of the huge growth and the need for emergency medicine. And we had proposals to add more and more waiting rooms, to add more patient rooms in that facility. And instead what we did was we sat down with industrial engineers and we laid out, using computer simulation, a new way to deliver care. And we're seeing more and more of this in healthcare in the US, using approaches like Lean. Lean is the system that Toyota uses to make cars more efficiently. And using these engineering principles, finding ways to create tremendous efficiency in healthcare delivery. And in our case, we didn't add more waiting rooms in our emergency room. We got rid of the waiting rooms because waiting rooms are capacitors on a circuit board. We don't need more capacity. What we need is better throughput. So we rewired literally the entire emergency department, removed the waiting rooms, and found ways to position physicians, nurses, and other healthcare practitioners to move patients through the system much faster and much more efficiently. We've literally had patients that have entered and left our emergency department in 7 minutes using this system. The long delays in getting through the ED have been reduced. The only delays that we have now are getting the patients from the emergency department up to the hospital, because many times our hospital beds are full, and that creates some real interesting situations for my team. But again, that's how these types of approaches, and why being part of a university is so important, because we can leverage the scientific strengths of the university in areas like engineering and translate that into improved healthcare delivery. And then in patient care, increasing focus on prevention and community health. We've developed something called patient-centered medical homes, where patients are seen by a team of nurses, physicians, physician assistants. Their data sits in a data repository, and they have this continuum of care that tries to keep them out of the acute care setting as much as possible. One of the things that we did, and this is a challenge right now, as you know, we're going through our healthcare reform in the United States and the formation of accountable care organizations where you're paid a single payment for care, as opposed to what we've had in the US for years, which is basically what we call fee for service, and you get reimbursed for every interaction you have with the patient. We're moving to a system where the physicians and the hospitals together get one single payment, and they have to manage the health of a patient for some period of time. To prepare for that, we took all of Penn State's what we call lives, those are all the faculty and staff and retirees, about 75,000, and we went into a 10-year partnership with Blue Cross in Pennsylvania, where we are now at full risk for our patients, for our population of Penn State employed faculty and staff, and we're working to manage their care. We instituted this first on the Hershey campus 7 years ago, and historically our increases in healthcare costs for that population were running somewhere between 10 to 12%. Many of our peers were even higher. And consistently now for the past 6 years, we've kept those increases to 6% per year, which again still sounds like a high number, but about half of what had been running historically. And again, in community outreach, we know, and this is some of the real exciting work done at the Association for Academic Health Centers, that social determinants of health are extraordinarily important to addressing health status. And it's a focus that we've had here in the United States for the past several years through the AAHC. Healthcare, though it's $3 trillion of the US budget, accounts for 15% of an individual's health status. Genetics accounts for 25%. But social determinants of health make up 40% of an individual's health status. The choices we all make. Do we choose to eat excessively, not have exercise, smoke, abuse drugs, drink alcohol? It's the largest proportion of the contributor to a person's health. And health status is defined as, do you live to your expected life expectancy? And do you rate your health status anywhere from excellent to poor? The largest determinant. So imagine, here we are spending $3 trillion educating a whole cohort of students. We have to focus on education and also interaction around improving those social determinants of health. So we do things that don't seem very big at a glance, but the impact on the community is huge. Starting a community garden to get people to exercise and to think about healthy eating. Starting a wellness center, focusing on community thinking about drug abuse, alcohol abuse, exercise, and screenings in the schools, in the community, screenings out in the community. These are very important and ultimately will impact health status not only in our region, but literally around the nation and the world. So all these together are included in our 5 strategic imperatives. This is part of our strategic plan to achieve the highest level of quality, safety, and value, to educate and invest in our people for personal and professional success, to create an extraordinary patient experience, to create innovation through research, and finally to develop and differentiate our regional integrated academic healthcare system. This is what every one of our 10,000 faculty and staff focus on each and every day that they come to work. And we've seen real benefits from this in terms of how we've done financially, and this is just a chart that shows our financial growth over the past 6 years. This is the medical center budget. This is the college budget. The college budget is made up of tuition and grants and philanthropy. The medical center budget, it's about $1.6 billion most recently. We transfer half of our operating margin. So those are the dollars that are left after we've paid all of our expense. We transfer half of that margin to support our academic mission, because we believe that as a fully integrated institution, that is our responsibility. It's not just to take care of patients, it's not just to do research and teaching, but it's to bring them all together. And if we truly believe that, we have to integrate the budgets to do it successfully. So in the most recent years, it's been roughly about $60 million that goes from the clinical side of the ledger to the academic side. And again, when we look at that Venn diagram of our 4 mission areas, this is how it really pans out. Our patient care supports our research. We know that even though the NIH grants are very coveted, for every dollar we bring in, we have to support that with 25 cents on the dollar, because it doesn't fund the full cost of research. A medical student tuition does not cover the full cost of education, so we have to support that from our clinical budget. And all that great work that we do in the community, community gardens, community outreach, educational programs at schools around health and wellness, that costs money too. But at the end of the day, we think that to have this be fully integrated and to have it fully successful, we have to have these transfers. The challenge is going to be, as healthcare reform continues to move forward in the US, inevitably these kind of margins will become a thing of the past. And the challenge for us is, how are we going to find the dollars and efficiencies to continue to do this successfully? We believe that the only way we can do this is through harmonizing these 4 missions, to find efficiencies in each that inform the other, to make our processes as efficient as we can possibly have them. If we try to separate them out, I personally believe they will fail. If we can continue to integrate them more and more and achieve that type of harmonization, it offers us the opportunity to maintain the success of these programs and the impact that they have on our region and on the nation. And we see that as a huge opportunity, and it's our responsibility to do it successfully. Of course, philanthropy is very helpful. These are some of the dollars that we raised through gifts. And I'll just end on this slide. There is so much commitment that the Penn State undergraduate students each year put on a dance marathon to raise money for our patients, our children, pediatric patients with cancer. These students, these undergraduate students on the main campus, are so committed that this past year they raised $12 million, over $12 million, going around to street corners with cans and asking for donations. In total, since the students started this program, they've raised over $100 million for pediatric cancer at our children's hospital. And as I tell all of the faculty and staff, if this is what a bunch of undergraduate students can do in their free time to put on one dance marathon a year, imagine what we can all do together each and every day. Thank you very much for your attention. It's an honor to be here. Thank you.